Hello, everyone. It's Dr. Prabakar. Hi.
Hi, how you doing?
Good. How are you?
Fine, I'm Suzanne Slonim. Nice to meet you.
Yes, nice to meet you. Thank you so much. I'm just started this live, and I'm just waiting for people to hop on. And
I feel very
great.
self that I actually got on successfully
Yeah.
before the thing started.
Yay. I know. My goal was to get on a few minutes early just to avoid any technical glitches. Um,
So,
yeah. What was that?
are you in San Francisco?
Yeah, I'm in Oakland right now.
Oakland.
Yeah, I'm in Oakland, yeah, in the Bay Area. So this is my week off because I was supposed to be traveling, and of course I canceled it because of Omicron. So I have a week off to, catch up on stuff. So yeah.
Great.
Um, all right, let's get started. Hello everyone. It's Dr. Prabakar from TheFibroidDoc, and I am so excited today to have a very special guest, Dr. Slonim, from Texas, right? Yes. And she is going to tell us all about uterine fibroid embolization. I am so excited about this topic, and I've actually tried to get her on since the end of last year. Um, we have a lot of alternatives to hysterectomy for patients suffering from fibroids, but in my opinion, UAE or UFE is one of the less talked about and one of the things that people are really afraid about, including doctors, including OBGYNs. So I really wanted to bring her on to talk to us today about this. So thank you so much, Dr. Slonim, for being here and taking time out of your busy schedule. And so let's get started. So I would love to hear a little bit more about you and, kind of how your training and how you ended up specializing in UFE.
I'd love. So I trained kind of back and forth across the country. I went to medical school in DC. I did my internship in Los Angeles. I did my residency in Boston. I did my fellowship in Northern California.
Oh,
And I worked in academic medicine in Northern California for 5 years after my training ended. And then I settled into a practice in Dallas doing, so my specialty is interventional radiology. And I was in a practice doing general interventional radiology. We do procedures all over the body with imaging, kind of like what cardiologists do in the heart with balloons and stents. We do that everywhere in the body, and we do the same types of procedures in the other organs besides the blood vessels. So I had a very busy practice in a hospital, and then I had the opportunity to leave the hospital and joined a group where they said you can do whatever. And I said, I want to treat fibroids. So they let me do it. And I've been able to build a practice where all I do is treat fibroids without surgery. So it's a great field, and there's the potential to offer help to so many women, and I love it.
absolutely. Wonderful. What made you pick, out of all the parts of the body, what made you pick like fibroids and specializing on that?
The reason is because it's something that I think is important. I care about it. I am opposed to unwanted hysterectomy. If
Sure.
a woman wants a hysterectomy, great, and sometimes definitely the way to go.
Yeah.
But if a woman is not given any options, that makes me angry.
Yeah. Yeah.
So,
No, that is so true. I think a lot of, I always cringe when I ask a patient, so why did you have a hysterectomy? And they're like, I don't know. My doctor said that that's what I had to do. And I'm like, oh no.
yeah,
So,
I'm strong about, and I'm good at it. I enjoy doing it, and so I just decided to try
that's
it.
that's
So,
awesome. Wonderful. So can you tell us what embolization means? What does
so
that word mean?
means blocking something. Let's see. Embolization generally means flowing through the bloodstream to cause a blockage. So when you get a pulmonary embolism, blood clots that come usually from your legs flowing through the bloodstream and blocking the blood vessels in your heart, in your lungs. But we do intentional embolization to treat problems. So we stop bleeding in the intestines by and embolizing, blocking, we inject substances to block the blood vessels as bleeding. We do embolization to treat tumors. So we'll inject either stuff to block the blood flow or chemotherapy agents or radiation to treat tumors. There's lots of areas around the body where we intentionally embolize, and fibroid is one of them, because there's such a rich blood supply to the fibroid, because it requires such a rich blood supply. If we threaten that by blocking it off, it will kill the fibroids.
Yeah, yeah, I'm familiar with embolization from OB, for obstetric hemorrhage. That's one of the last kind of things that we're able to do prior to having to do a hysterectomy. So yeah, such a cool tool. So
I don't know how old you are or how long you've been in practice, but that's how UFE started.
Yeah.
Doing embolization to stop a woman from bleeding to death after she's had a pregnancy complication, and it was incidentally noticed women with fibroids who had this done, their fibroids shrank.
Oh, I'm about 7 years out of fellowship, but yeah, I didn't know that was like the first use of it, but it makes sense. It definitely does. Yeah. So who are the best candidates for this procedure for UFE?
The best candidates are women who are not trying to get pregnant, who have multiple fibroids. Ideally, they would be on the inside of the uterus, where the baby would be. Ideally, it would be in the wall of the uterus, or even on the outside wall, outside the uterus, and who have symptoms because of them.
Yeah. Okay. Now, is there like a size limit typically?
There really is not a size limit. There's a higher chance for problems once you get above 8-10 centimeters. But I've treated fibroids up to 22 centimeters, and they've done well. It's possible to get a very good result.
Mm-hmm. Okay.
My favorite is lots of small and medium-sized fibroids, because we're big effect.
Okay, great. That's really good to know. Now, you mentioned that one of the ideal candidates are people who are not trying to get pregnant. Now, recently I read a paper where they were looking at outcomes for pregnancy and non-pregnant women, and they said, it actually looks pretty good. The data looks good. And when I was training, we were kind of thought like, okay, if somebody's trying to get pregnant, this is an absolute contraindication. Embolization is a contraindication because it can, mess up the blood supply to the uterus and have issues later when a woman does become pregnant. So the answer is probably not cut and dry, but I would love for you to talk a little bit more about pregnancy, because so many women with fibroids are of childbearing age. So if you talk a little bit about how you would counsel a woman who is trying to get pregnant.
Women come to me trying to get pregnant all the time, and I'll tell you how I do counsel them. So there have been, I think, 2 meta-analyses done, which for those who are non-medical on the call, they take all the literature, all the studies that have been done, compare, looking at a certain topic, and they put them all together and try and draw a reasonable conclusion from that. And so of those that have included thousands and thousands of women, and it's looked at pregnancy between myomectomy, which is surgery to remove the fibroids and leave the uterus in place, versus UFE. And what they've found in both of those meta-analyses was that the pregnancy rates are very similar. It really doesn't make that much of a difference between the two. But they don't really look at the live birth rates. They haven't compiled data that shows, yes, these women get pregnant, but they end up with a baby. There's only been one study that was a randomized controlled trial comparing pregnancy outcomes in women with fibroids. They randomized between myomectomy and UFE, and the pregnancy rate was best in the myomectomy group. The birth rate was best in the myomectomy group. The miscarriage rate was significantly higher in the UFE group. Mm-hmm. It's not a very large study, but it's the only study that's out there. So based on the meta-analysis, a lot of gynecologists and a lot of interventional radiologists are doing UFE women who are trying to get pregnant. My personal opinion is I prefer not to. Mm-hmm. We'll do it. I feel better about it in someone who's younger. If someone is over 35 and really getting pregnant is a top priority, I really believe that doing is going to hurt their chances more than help them in most situations. I always get a fertility doc consult, and it's a kind of a team approach of what's the best thing to do. The only time I've ever had fertility doctors tell me to do the UFE is when they really think there's not much chance of the patient getting pregnant anyway.
Mm-hmm. Sure.
I will tell you, I have done UFEs on women who are trying to get pregnant. I do it in the setting where, number one, she understands the risks. Number two, the gynecologist has said either she's not a candidate for a myomectomy, or she said, I will not have surgery, period and end. So
Yeah.
I will, if someone's sort of being threatened with a hysterectomy when they're trying to get pregnant,
Yeah.
absolutely to do a UFE for that woman.
Yeah.
And that woman that I'm thinking of right now has 2 little boys. So,
That's great.
well.
Yeah. Okay. Awesome. Are there any patients who come to you and in your counseling, you look at them and you say, okay, you are not a candidate for UFE. Like they've exhausted some of the medical options. They don't quite want a hysterectomy or myomectomy. Are there any like contraindications or reasons you would say, no?
There's a few. They're rare. Probably the most common one, unfortunately, is we do an MRI. We always do an MRI to evaluate what's going on, and we find something unexpected, an ovarian mass or a fibroid that looks very atypical, that I'm concerned that it could be hiding something, threatening. I'm talking about a cancer.
Yeah.
If there's that, absolutely not. If there's an active infection going on, if you've got endometriosis, you've got infection in your pelvis, I'm not going to do it. If you've had pelvic radiation, I'm not going to do it, because that already is going to compromise the blood flow in your pelvis. And if I go in and then block blood supply to the fibroid, it could kill the whole uterus, and I don't want to do that. Women pregnant, I'm not going to do it. And actually, I have women calling me who are pregnant saying, "Can you UFE?"
Wow.
So,
yeah.
No.
Right.
I think that's it. There are plenty of women who have, if you have a uterus that's coming up to your sternum, it is often my advice for you to have a hysterectomy, because that's a lot of bulk in there. And even if it shrinks 50%, that's still a lot of bulk in there.
Yeah.
A lot of refuse. And most of the time they're very happy with their result, but it's huge. That's a huge burden in your abdomen.
Yes. There is a place for hysterectomy. One of our viewers, the fibroid pandemic, says UFE has changed my life. Yay!
Yeah.
So if a patient says, okay, fine, I really want to do this, I've tried all these medical options, what does a typical procedure day look like? What can they expect when they come in and, from beginning to end?
It depends on the type of practice you go to. Probably the standard practice is you go into a hospital, go through admitting, and you go to a pre-op area where they'll start an IV and put you in a gown and have you do a bunch of paperwork and documentation. The doctor will come and either meet you or reintroduce him or herself to you. And then they'll take you. They'll give you a chance to ask questions. They'll take you into the procedure room and give you usually some medicine in your IV to make you sleep or sleepy. And I think probably still the majority of procedures are done through the groin, through the right groin. The procedure depends who's doing it. If I'm doing it, it takes about an hour to do.
Okay.
Else is doing it, it may take longer than that. Hour, 2 hours. I've seen them last longer than that.
Yeah.
When the procedure's done, they'll take the tube out. I think most centers are using a device to close the puncture at the groin. So your recovery period, if they use that, is 2 hours laying flat. If they don't use it, it's 6 hours. Again, depending on the technique, this procedure can be very painful. And so if you have seen a physician who does this technique, you probably will be in a lot of pain, and you'll probably be kept in the hospital overnight for pain control. Most women go home the next day. Some doctors are doing special procedures, nerve blocks that block the pain in the first period after the procedure, and then it's not so bad. You may go home with hopefully a well-structured schedule of medicines to take manage your pain when the nerve block wears off.
Okay, you're talking like a tap block?
It's a little different, but I'm not going to reveal trade secrets.
Okay, okay. Um, so, when I was in residency, that's what I always heard about. Like, oh, it's so painful. You got to be admitted overnight for like a PCA. And so you're saying it's like, yeah, oftentimes that is the case, right?
Often that is the case. And if you're not block, you absolutely want a PCA. A PCA, again, is viewership doctors, or are they patients?
No, it's just, patients. So yeah, yes.
Stands for patient-controlled analgesic, which is pain control. So it's a machine where you push a button to give yourself a dose. You can control how much pain medicine you're getting. Mm-hmm. It's great. For me, it's a requirement. When I was doing them in the hospital, it's a requirement. So, and my experience is that the gynecologists who are strongly opposed to UFE are ones who worked with interventional radiologists who did not take care of their patients. Mm. They wash their hands of it, they go up, they'll give you some pain medicine, see you on the ward, and then they call in a discharge order the next day. Well, the patient pain and calls the gynecologist.
Yeah.
That's a completely, in my opinion, inappropriate way to manage the patient. But patient suffers, and the gynecologist gets calls after calls after calls with symptoms, and so they're like, I'm never ordering a UFE again.
Yeah.
But if you have somebody who is dedicated and who focuses on taking care of you, then it's not such a bad experience. And gynecology. So listen, I think I'm up to 200 gynecologists who refer to me. So it can be a very effective and a tolerable procedure.
Absolutely. Okay. Janima, hello, Janima. If anyone has questions, please go ahead and send that in the chat. SN West 3 says, how do you do it? So she just actually did go over that.
I will say, people go through the groin. I go through the wrist, the artery right here in the wrist, which it seems like a long distance to go to get to the actually a straight shot, and it actually is easier to do it from the wrist, and it's more comfortable for the patient.
Yeah. Okay.
For about 5 years now. Only time I go from the groin. I actually did one from the groin last week because the woman has a dialysis graft in her arm. So
got it. Okay. And you said, IV pain medication, so it's some continuum of general anesthesia, but it's not like an intubation.
Well, most people do it with moderate sedation.
Moderate sedation, okay, yeah.
I have an anesthesia when I do it, and they use propofol. It counts as general anesthesia, but they don't get intubated.
Yeah, okay, all right. So we talked about UAE and pregnancy. So tell us a little bit about, what is unique about your practice and kind of how you do this procedure. Now, as you said, a lot of times interventional radiologists will do it, but they're doing a lot of other interventional procedures as well, anything that comes into the hospital. So it's not like they're specialists in this, but I know you have an institute. I mean, you are really like, this is all you do. So
last almost 6 years, all I do is UFE. That's all I do. And my approach is very similar. I have really tapered my protocol for optimal patient comfort, patient care. So women know what's going to happen before they come in. We do a consult in the office or televisit. We review the images together. She knows what's going on. She knows what the plan is. We do the procedure. And, pretty much from the time we decide the procedure is going to happen, she has my cell phone number, and patients call me all the time, and I answer the phone. Last week in the office, practically crying. She was so happy because she called me in pain at 1 a.m, and I answered the phone. She's like, I can't believe you answered the phone.
Yeah.
But it's rare, you don't have to take middle of the night calls very often when your system is in place to manage pain before it gets out of control.
Yeah.
What makes me unique is that this is all I focus on. my priority is to take care of the women that I treat. And so they can reach me when they need me, they reach me. That's just it. And my staff is all very dedicated. If there's somebody who calls on the weekend and it goes to the office instead of me, somehow they find out and I get, they say, hey, so-and-so is looking for you, and they get a call.
Yeah. 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 That's great.
The way medicine should be practiced.
Yeah. Yeah. Tell me about it. Definitely. Lucitac says, how safe is what is sent through the veins? So I'm assuming you're talking about the little, the particles. Yeah.
There's a couple of different varieties that are used. They are all FDA, well, they're not all FDA approved for fibroids. The ones that I use are FDA approved for fibroids, been used in the body for decades. There's pretty much never been a report of an adverse reaction. And I want you to understand that these are not released through the veins and arteries and just go flowing to the fibroids. We put the tube right next to the fibroids and inject it right there. So even though I'm putting the tube in the wrist, the back end is injecting here, but the tip of the tube is in the fibroid blood vessels. So the particles come out and flow right into the fibroids. They're not going all over the pelvis or through the rest of the body. There's no way for them to get through the rest of the body. There's no way for them to get to your heart. There's no way for them to get to your brain. And they have a good track record of being safe.
Great, great. And then the next couple of days after the procedure, as you said, some people do get admitted overnight. And then what can they expect after that? What kind of pain meds are they taking? Any discharge? Can they return to normal activities pretty soon?
So I think a fair statement would be the recovery is a week. They're going to be pretty uncomfortable. For the worst of the pain is the day and the next day. By the third day, most women are feeling much better, and they're going to be getting heavy pain medicine. So most practices do a combination of an anti-inflammatory like ibuprofen, or naproxen, so Advil or Aleve, Tylenol, and a narcotic.
Okay.
And so in my patients, most women take narcotics for about 5 days. After that, they don't need them usually. If the pain's not under control, you're likely to have nausea and vomiting. If the pain's under control, the nausea tends to not be bad. You're going to have a low-grade fever that can go on for a few days to several days, and the medicines you'll be taking will be taking care of that.
Mm-hmm.
Run down your body, even though you just have a tiny little spot on your wrist.
Yeah.
Your body has been through a huge deal. Part of your body is dying, tissue is dying, and everything you're feeling is because your whole system is set up to not let that happen. And when it happens, it's your body thinks it's a catastrophe. So you're going to be uncomfortable. Everything is going to be very tender and sensitive. Most women are fine to go back to work at 1 week.
Mm-hmm.
Don't really feel back to themselves for about 10 days.
Okay.
And that women who bleed all the time, they tend to stop bleeding the day of the procedure.
Yeah.
Women who don't bleed like that, it's very common to develop spotting and can go on for weeks. And that's normal up to 8 weeks.
Right. Okay. All right. Now, where can people find you? Do you see people from around the country? Like, can you tell us a little bit about, for a woman who wants, this procedure done by you, how do they go about contacting you and finding you?
So I have a website. It's fibroidfree.com. You can reach me there. I treat a lot of women in Dallas. There are women who come from other areas to see me as well. And I'm happy to see. There are lots of doctors who do this procedure, and some of them do it very well. There's a center in Georgia that does a lot. I think there's a new center in Denver.
Mm-hmm.
If you look, you'll find it's really better if you see someone who does a lot of them.
Of course, yes.
Just like, but fibroidfree.com. There's a website called Ask for UFE, ASK4UFE.com, and you can search for fibroid specialists in your zip code, and they'll.
Mm-hmm. That's great. I mean, this is such a much needed service. I think one of the ones that are less, one of the treatments for fibroids that is less talked about. So I'm so excited that you are dedicating your work to this, and I'll be happy to send patients. And for all those listening, I mean, I hope you've all learned from this session from Dr. Slonim. And if you're listening to this afterwards, please comment with hashtag replay. I would love to see you guys on there, and also feel free to ask any other questions. And yes, also Fibroid Free MD. Yes, please follow Dr. Slonim at Fibroid Free MD. Check out her website. Do you have any other last minute?
No, thank you very much. And thank you for the work that you do.
Thank you. I mean, I'm mostly, you know, my niche is fibroids. A lot of women come to me after trying a lot of things. But I think even with everything that we have now, luckily we have more than just birth control pills now. You know, we've got Orion and, you know, Orlissa and things like that. And of course, I do a lot of robotic and laparoscopic myomectomies and hysterectomies for those who really tried everything and, you know, are just so done with it. But I think still UFE has a place, and it's just one of those, in my opinion, even through training, just one of those things that is less talked about. So I really wanted to bring more light to it, to my followers, and yeah, hopefully more people can have another option now to treat their fibroids, especially those who are eventually trying to get pregnant. So yeah. Awesome. Well, thank you so much. I really appreciate your time, and we'll be in touch.
All right. Have a good night.
Okay, you too. Bye.
Bye.
Bye.